Welcome to you all on Zoom today for our 8th seminar of the Aphasia CRE Seminar series.
I've just still got to write up some notes from the sessions today.
I'm Caroline Baker, co-facilitator of the seminar series. I would like to begin by acknowledging the Indigenous elders, past and emerging, and pay respects to the traditional custodians of all the lands on which we meet today. We warmly welcome you, and we acknowledge the difficult and uncertain time of COVID-19 for everyone. And we are thinking of healthcare staff in our hospitals and communities, serving patients, clients and families. Today, we are delighted to have Dr. Robyn O'Halloran as one of our associate investigators at the Aphasia CRE from Trobe University. Before I introduce Robyn formally, I'd like to cover some housekeeping. As you know, we've moved our seminars to an online audience only due to COVID precautions. And with the whole world discovering the wonders of Zoom, you may experience technical issues because of internet capacity in your area. If this happens to you, please be patient. Retry the Zoom link or watch the recording of the seminar at a later date. Our apologies in advance if there are any disruptions to your viewing during the seminar. Occasionally, attendees will join us late, and to enhance everyone's Zoom experience, please mute your microphones, turn off your videos and minimise the Zoom gallery. Thank you. So as I mentioned, this seminar is being recorded on Zoom and will be available to access along with past webinar videos via the website. Just click on the resources tab, and the videos are usually uploaded 1 to 2 weeks after each seminar, and we're aiming to get this one out on the 28th of March. Questions for this seminar will be aided by the use of Slido. You can log in anonymously or with your name and ask a question during the presentation. Our event code is 2509. Enter your question under the questions tab at any time throughout the presentation, and you will also be able to see questions asked by other audience members. Like a question by clicking on the thumbs up to show those of most interest to the group. It's a great way to engage with the presentation experience. Robyn will answer as many questions as time will allow at the end of the presentation. We would also love you to provide some feedback at the end, but I'll explain more of that towards the end. Please join us on social media. You can connect with us on Twitter, and feel free to use the hashtag Aphasia CRE. Please join our community of practice as a member of the Aphasia CRE. We welcome people with aphasia, their family, friends, health professionals, researchers to the community of practice. Benefits to members of the community of practice include a monthly newsletter, updates about events and activities, contributions to research, networking opportunities and more. I am delighted to introduce Dr. Robyn O'Halloran, Discipline Lead of Speech Pathology at Trobe University. Robyn also holds an Honorary Speech Pathology Research appointment at St Vincent's Hospital in Melbourne. Robyn contributes to projects under research programs 1, Neurobiological and Psychosocial Mechanisms of Aphasia Recovery, and program 2, Treatment Effectiveness Across the Continuum of Care. She is at the forefront of speech pathology scholarship on the identification of environmental factors, including psychosocial factors that impact aphasia recovery. She has also published widely on functional communication assessment and treatment of hospital patients with communication disability. She has co-authored 48 peer-reviewed publications, including the Inpatient Functional Communication Interview and 4 book chapters. Her national and international reputation in this field is reflected by invitations to deliver workshops for Speech Pathology Australia, American Speech Language Hearing Association, and a keynote at the Aphasia New Zealand Conference on Accessible Environments. Robyn contributed to the Australian Aphasia Rehabilitation Best Practice Recommendation on accessible environments. And she has also been co-editor for Topics in Language Disorders in 2017 on creating accessible environments for people with aphasia. Thank you so much, Robyn, for being with us today.
Great. Thank you, Caroline, and thank you, Michelle and Kelly, for helping to set up today. I'd also like to thank, I'll just move that here. I'd like to thank the CRE too for the opportunity to talk to you this afternoon about hospital care for people with aphasia, and I'm going to take a long-term perspective on this topic. Just one disclosure before I start. I'm an author on the inpatient functional communication interview, as Caroline said, screening, assessment and intervention. This is a set of clinical resources that was published earlier this year by Plural, and I receive a royalty on the sales of that. Okay, so what I want to talk about in the next 45 minutes is hospital care for people with aphasia, and I'm going to take a long-term perspective on that. And to help us do that, I thought it would be useful to reflect on the hospital care of children over the last 80 years and see if we can draw any lessons from that. And if there are lessons, and I think there are, what might they be as we think about the hospital care of people with aphasia. And the only other thing I want to say at this point is that I started preparing this presentation about 8 weeks ago, well before COVID-19. And although that changes the context of this talk, I don't think it changes the message. I certainly hope it doesn't. Okay. So in the 1940s, best practice hospital care for children meant a complete focus on the child's medical condition. That was the sole concern. And it was believed that a major threat to these sick young babies, infants and children was getting an infection. So to minimise this risk, all inpatients, regardless of their age, regardless of their medical condition, were separated from their parents, and visiting hours were strictly limited and enforced. I found the rules and regulations for Royal Children's Hospital in Melbourne in 1944-45. And I'll read out these regulations around visiting. But as I'm reading it, I want you to remember that when we're talking about patients, we're talking about babies, toddlers and children. So patients are not allowed visitors unless they've been in the hospital for a period of 4 weeks, after which time only the parents or guardians, no friends or relatives are allowed, are permitted to visit on the first and third Sundays in each month between the hours of 2 and 3:30 p.m. Parents or guardians of patients dangerously ill are allowed to visit as often as the doctors consider necessary. Parents or guardians of patients in the baby wards and the infectious wards are only allowed to visit with the special permission of the medical superintendent or his deputy. These regulations regarding visiting are also apply to hospital sections at Sherbrooke and Macedon and have been made to protect the interests of the patients in the hospital. Even when parents were allowed to visit their sick children in hospital on that first and third Sunday of the month, they were not allowed to touch or hold their children for fear of infection. The fact that children became upset and distressed on being separated from their parents or carers was accepted as the way things have to be, because the primary concern, the only concern, was the child's medical condition. And there was a widespread belief that it didn't really matter. The thinking was that infants wouldn't remember and children would soon forget when they were feeling better and back at home. Dr. John Bowlby, a psychiatrist and psychoanalyst, looked more closely. He spent his early career working with children and teenagers with behavioural problems, and he was very interested in the emotional distress experienced by infants and young children when they were separated from their carers for long periods of time, such as when they're admitted into hospital. And to help understand the child's experience better, he made a film in 1952 called A 2-Year-Old Goes to Hospital. And there's a 90-second clip of this film on YouTube, and it's well worth watching. And in it, you'll see 2-year-old Laura, pictured here, clutching her teddy. And then when the nurse comes to talk to her at playtime, she bursts into tears and says, "I want my mummy." Bowlby did more than just increase everyone's awareness in hospital. He also began to draw connections between a child's early experiences of separation and their psychological well-being in adult life. He developed a theory called attachment theory. And in that theory, he argued that a child needs to develop, I'll shut my window, hang on. That's better. Okay, so he argued in attachment theory that a child needs to develop a secure relationship with at least one primary caregiver for healthy social and emotional development to occur. And with this, the child could grow up with the ability to form healthy, secure relationships in their adult life. He also argued that if a child didn't get the opportunity to form this secure attachment in childhood, or they were separated from their primary carers long enough that it started to damage the child's ability to form a secure, healthy relationship, then the child was more likely to experience difficulty forming secure relationships in their adult life and was at greater risk of mental illness in adult life. This theory prompted a great deal of research, and with evidence over decades, attachment theory has been shown to hold true. So through Bowlby's careful observation, developing theory, then building research evidence, he and many others were able to argue that hospital rules that separated children from their primary carers not only caused children distress in the present, but was laying the foundation for the child to have poorer psychological health and well-being in the long term. And it must have been hard to believe, but slowly over decades, attitudes changed, healthcare providers developed new skills, new knowledge, hospitals developed new policies and procedures around visiting, and the physical environment also began to change. So if we fast forward to 2012, and this is the design of the new Royal Children's Hospital in Melbourne. And if you notice that yellow bed in the background there, well, that's a bed for the parent. And if you're a parent of a child who needs to go to hospital, there's an expectation now that you will be packing your bag as well. Hospital care for children has completely transformed since the 1940s. Not only do we strive to give children the best possible care for their medical condition, we also can understand and accommodate the child's other needs so that hospital care doesn't in any way undermine the child's health and well-being in the future. So are there any lessons for us who provide hospital care for people with aphasia? If we take as a given that patients with aphasia are in hospital because they need treatment for their medical condition, whether that's stroke, cancer, a hip replacement, or COVID, reflecting on the hospital care of children, I think it prompts us to ask two key questions. And the first one is, do people with aphasia have other needs in hospital? And the second critical question is, are there consequences on the person's health and well-being in the long term if these needs are not met? So let's look at the first question. Do people with aphasia have other needs in hospital? There's a growing number of qualitative research and some memoirs on this topic, but this literature does need to be synthesised. So I'm just going to highlight a couple of key papers here. One paper by Clancy and colleagues, they interviewed people with aphasia in the UK about their experiences of stroke care in hospital. And one participant with aphasia, Sue, said, and that was more frustrating because they were doing things and checking blood pressure and taking you for a scan, and you had no idea what was happening because your brain wasn't taking in what they were doing, telling me. And I wasn't taking that in, and I had no idea what was going on. So I felt totally at a loss. In another qualitative study by Hemsley and colleagues, a participant described their loved one in hospital with aphasia. And they said, he couldn't communicate in the ward. He fell out of bed. In a ward, if you needed help, you had to push a button. He couldn't yet do that. So when he needed to go to the toilet, he just thought, well, they're never going to come. And of course he couldn't walk, so he just fell down. Deborah Hirsch has also talked to people with aphasia about their experiences in hospital. And here's an excerpt of Hirsch talking to Eleanor, a woman with aphasia, about an interaction with a doctor. So Hirsch, as interviewer, says, okay, so he didn't address you, he addressed your family for questions. Okay, sorry, yeah. Okay, so all the information was through the family. Yes. Yes, okay. Again, looking back on it, do you think that was because he didn't know that you could understand what was going on, or he was too busy to give you the time? I don't know. I don't know. X-rays family? Me? Nothing. Nothing. And one final example, and this is from Georgia Blaine, an Australian writer who died of a glioblastoma in 2016 at the age of 51. In her final year, she wrote a memoir about her experience of losing her language. And this is an excerpt of her experience of speech pathology. She wrote, "The speech pathologist came to my bedside. She was young and softly spoken. Initially, she asked me to name objects that she held up for me, a pen, a cup, a watch. Then she gave me cards with illustrated scenarios on them. They were old-fashioned, like the learn to read books I'd had in my childhood. A woman in a frock doing the dishes, while outside her husband is pulling up in the driveway, a cat about to dart across the path of a car. She asked me what was happening. No, I tried to say, this isn't the problem. Then she asked me to name all the words that I could think of beginning with F. All I could think of was fat fuck. I couldn't think of any other words, but still, I didn't think she was getting anywhere near the heart of the issue. So these are just 4 examples, but if we go back to our first question, do people with aphasia have other needs in hospital? I think these examples suggest that people with aphasia do have other needs in hospital. They have the need for direct, effective communication with all their healthcare providers, their radiologist, their doctor, their nurse, and their speech pathologist about the issues that matter to them. But we also have a second question, and that was around, well, does this really matter? Should people with aphasia and their healthcare providers just put up with this poor communication? Is this the way things just have to be? Will people with aphasia soon forget when they're back at home and feeling better? Or are there consequences on the person's health and well-being in the long term if these needs in hospital aren't met. So is there any theory or any research evidence to help us? Well, there is at least one theory, and this has been proposed by Street and colleagues in 2013. And this suggests that communication between the clinician and the patient does influence patient health outcomes in the long term. This theory was developed on research between clinicians and patients where patients had cancer. And it proposes that clinician-patient communication can influence patients' long-term health outcomes, both indirectly and directly. So let's look at this indirect mediated path. So the theory proposes that when there's effective communication between the patient and the clinician, that this can lead to proximal outcomes of the patient feeling understood, satisfied with their care, trust in their healthcare provider, and a sense of feeling involved in their medical care. And this in turn can lead to intermediate outcomes such as better medical decisions being made, patients having a greater commitment to the treatment plan, a greater trust in the healthcare system, and a greater willingness to access the healthcare system in the future. And both proximal outcomes and intermediate outcomes can lead to overall health outcomes such as increased survival, less suffering, better pain control, greater functional ability. And they also proposed that there was a direct path, directly linking clinician-patient communication with these health outcomes of less suffering, better pain control, greater functional ability. So as I mentioned, this is a model that's been developed on patient-clinician communication with patients with cancer. But is this a model that might be applicable beyond cancer patients? Is there any research evidence at all that links healthcare communication between patients with aphasia and their healthcare providers with these proximal, intermediate, or long-term health outcomes? Well, if you look at what Street and colleagues call proximal outcomes, like patient understanding, patient satisfaction, trust in the healthcare provider, these are all concepts that are measured in patient experience measures. So is there any evidence linking patient-provider communication with patient experience or patient satisfaction? Well, there's one qualitative research study done by Tompkins and colleagues where they analysed the interview data of 50 people with aphasia about what factors influence their satisfaction or dissatisfaction with their healthcare. And interestingly, the factor that was mentioned most often that influenced whether patients with aphasia were satisfied or dissatisfied with their healthcare was having direct, effective information exchange with their healthcare providers. There's also a study by Hoffman back in 2005, and they looked at, Hoffman and colleagues looked at a large US Medicare beneficiary survey data set. There were 16 million people who self-reported communication disability on that survey, and they found that people who reported communication disability were significantly less satisfied with their healthcare compared to people who didn't report communication disability. So we've got some qualitative evidence linking patient-provider communication and satisfaction with care for people with aphasia. And there's also some evidence of an association between having any kind of communication disability and poor patient satisfaction. So what about health outcomes? Is there any evidence linking patient-provider communication involving people with aphasia and health outcomes? Well, health outcomes can be thought of in terms of negative outcomes or positive outcomes. And negative outcomes occur when a person is harmed in some way in the process of receiving care, and that's called an adverse event. And a positive outcome occurs when a person gets the outcome they're hoping for as a result of seeking healthcare and receiving healthcare. So is there any evidence of a relationship between patient-provider communication involving people with aphasia and adverse events? Well, yes, there's a large retrospective study was conducted in Canada by Bartlett and colleagues that found that patients with any kind of communication difficulty were 3 times more likely to experience a preventable adverse event compared to patients without any kind of communication difficulty. And there's also recently a study done by Sullivan and Harding who found that patients on a stroke ward with no functional communication were almost twice as likely to fall compared with patients with functional communication. And a fall is a serious adverse event in hospital. Interestingly, a lack of functional communication was the strongest predictor of falls rate in that study. So we've got some evidence here of an association between having a communication disability, like aphasia, and experiencing a preventable adverse event. What about positive health outcomes? Is there any evidence linking patient-provider communication, people with aphasia, and hoping to get the outcomes you want from healthcare? Well, there's an interesting study by Stransky and colleagues published in 2018. They looked at the 2012 US National Health Interview Survey dataset. They grouped the data into people who self-reported communication disabilities of speech, language, or voice disabilities and compared them with those who did not. And they found that adults who reported a communication disability were also significantly more likely to report higher rates of chronic health conditions compared to those who didn't report communication disabilities. And that adults with communication disability were significantly more likely to report fairer or poorer health compared to people who did not report having a communication disability. So here we've got some evidence of an association between having a communication disability and not getting the overall health outcomes that people without communication disability may be achieving. Okay, so let's take stock of where we are so far. We looked at the changes that have occurred in the hospital care of children, and that prompted us to ask 2 questions about the hospital care of people with aphasia. And the first question was, do people with aphasia have other needs in hospital? And I think excerpts of the research literature would indicate that the answer is yes. People with aphasia do have other needs in hospital, and one of them at least is the need for direct, effective communication with their healthcare providers about the things that matter to them. And the second question was, well, are there any consequences for the person's health in the long term if these needs are not met? And here I think the answer is probably most likely. We looked at a theory linking patient-provider communication with proximal outcomes, intermediate outcomes, and overall health outcomes. And we looked at some preliminary research evidence that indicates that people who have a communication disability, like aphasia, when they're in hospital, are at greater risk of a poorer patient experience, are at greater risk of a preventable adverse event in hospital, and are more likely to have more chronic health conditions and report poorer health overall. Do people with communication disability like aphasia have these poor outcomes because of poor patient-provider communication? We don't know. So clearly this is a very incomplete picture. And what I'm doing here today is hopefully also mapping out a possible research agenda for this area. But I do think as speech pathologists, we need to be open to the possibility that if we don't support people with aphasia and people with other kinds of communication disability and their healthcare providers to have direct, effective healthcare conversations about the things that matter to them. Not only are we allowing people with aphasia and other communication disability to experience real distress in the present, we may also be setting them up for poorer health in the future. So what can we do? Perhaps we can draw some inspiration from the design of the New Royal Children's Hospital, because for me this image encapsulates our ability as healthcare providers to think about a person's medical needs as well as our ability to understand and accommodate their other needs as well. And can we do this for people with aphasia and for people with any kind of communication disability in hospital? Well, I think we can, and I think we can do this by flipping our priorities. So what if our first priority as a speech pathologist, when we had that first contact with a patient in hospital, what if our first priority was addressing the patient's need for direct, effective healthcare conversations about what matters to them? That is, as speech pathologist, we could interview the patient about their ability to communicate about their healthcare in hospital, about what's happening for them. And as we're having that conversation, we can think about, well, can they communicate about their healthcare? And if we have any difficulty communicating with them about their healthcare, are there any supports or strategies that we can try to make it more effective? And what you're also aiming to do there is to give the patient at least one direct healthcare conversation that's effective. And then after that conversation, the speech pathologist could reflect on the patient and think about whether there was any evidence during that interview of any underlying speech or language or cognitive communicative impairment. So you're already starting to think about screening the patient for those underlying impairments with a view to formally assessing for those underlying impairments later on as indicated. And you could also reflect after the interview on your role in the interaction and think about what communication supports helped. Can I realistically recommend these supports to others on the healthcare team? You know, do they have the skills, the resources, the time? Is there support from the hospital around policy and procedure for them to give patients with aphasia these supports? And what you're doing there is starting to think about the environmental barriers that are present in the hospital that might be preventing healthcare providers to having these direct, effective conversations with people with aphasia. Okay. And this is what the IFCE say, the Inpatient Functional Communication Interview, Screening and Assessment and Intervention is about. It's a set of 4 clinical resources to support speech pathologists and the rest of the healthcare team have these direct, effective healthcare conversations with patients with communication disability like aphasia. So the resource number 2 is the interview, the speech pathology patient interview. It's a semi-structured interview the speech pathologist conducts about the patient's ability to communicate about their healthcare. And during the interview, you're trialling supports and strategies as they're needed. And this interview was developed on the basis of observation studies of patient healthcare provider communication in hospital. Resource number 3 in the IFCE is a set of impairment rating scales. So these are there so that the clinician can reflect after the interview on whether there was any evidence of a speech intelligibility impairment, a language impairment, or a cognitive communication impairment evident through the window of a supported conversation. So these rating scales, they're 3 separate rating scales. They're 5-point scales ranging from 0, no impairment evident, to rating of 4, complete impairment evident. And resource number 4 is a set of environmental questionnaires, and these are designed to support the clinician to think about the kinds of communication supports and strategies that are going to be needed to enable all staff to have direct, effective conversations with this patient. There's 2 sets of questionnaires, the individual one to set up supports for the individual patient with aphasia, and then there's an overall questionnaires that we've separated into questionnaires around what needs to be in place in the ward, what needs to be in place at the level of the hospital, and what needs to be in place in external agencies outside the hospital for healthcare providers and patients to get the support they need. And these questionnaires have been developed on the basis of a range of observational studies. So, resources 2, 3 and 4, how do they relate together? So the speech pathologist and patient do the inpatient functional communication interview, and on the basis of that interview alone, the clinician's thinking about whether there's underlying communication impairments, speech, language or cognitive impairment, and they're also thinking about the underlying supports that are going to be needed in order for this effective communication to be realised. And the clinician synthesises that information to come up with a healthcare communication plan for the individual patient. And you're probably wondering at this point what happened to resource number 1. Well, that is a nurse screening questionnaire, and that's been designed for nurses so that they can identify any patient who is admitted into hospital who will need communication supports in order to communicate about their health care. Patients who are identified on the screening questionnaire may be referred to speech pathology for a IFCI screening questionnaire to give you a sense of how it relates to the other resources. But what about the patient's medical condition? And I'm thinking here specifically about patients who are admitted into hospital with a sudden onset of aphasia. Does addressing a person's need for direct, effective conversations with all healthcare providers mean neglecting the person's language impairment, their aphasia? Well, in thinking about this, I went back to the Stroke Foundation guidelines and had a look at their practice points and recommendations. So one practice point is that all stroke survivors should be screened for communication deficits using a screening tool that's valid and reliable. And what I'd like us to think about is whether we can screen patients, just screen, we're not talking about assessment, but just screen patients for communication deficits by conducting a bedside interview and then completing speech, language and cognitive communicative rating scales. We've done one study to look at this. We interviewed 13 to 15 patients on the IFCI. We then rated them on speech, language and cognitive communicative rating scales, and then we tested them on 3 standardised measures: the assessment of intelligibility of dysarthric speech, the WAB, and some subtests of the SCAT-B. And as you can see, we got some good correlations between the person's rating on each of those 3 rating scales and their score on these standardised measures. So I think this is an approach that is definitely shows promise. We also looked at the reliability of the rating scales in that we compared 2 speech pathology raters. One did the interview and then the 2 of them independently rated the patient on the speech intelligibility scale, the spoken language scale and the cognitive communication scale. We got very good absolute agreement and overall agreement on the speech intelligibility and cognitive communication scale. We didn't get good absolute agreement on the spoken language scale, but we did get better overall agreement. So again, I think we're not quite there yet, but it's definitely rating people's first impressions of communication deficits on the basis of an interview shows promise. Other practice points: the Stroke Foundation guidelines say that where a stroke patient is found to have aphasia, the clinician should explain and discuss the nature of the impairment and should just teach strategies or techniques that may enhance communication. We're also guided to use alternative means of communication as appropriate. So I'm thinking that as you conduct the IFCI or that bedside interview, there's an opportunity there to begin to explain and discuss the nature of the impairment, because you're talking to the patient about their healthcare situation. And you've also got the opportunity to trial strategies and use alternate means of communication during that first contact. So this provides an opportunity for us to start implementing the good practice points of the stroke guidelines from the very first contact. Another good practice point is that environmental barriers facing people with aphasia should be addressed through a variety of ways. And thinking about that practice point from a hospital perspective, can we address the environmental barriers that are present in hospitals that prevent people with aphasia participating in their healthcare? It's one way that we can address this Stroke Foundation guideline in the hospital setting. And another practice point is that the impact of aphasia on functional activities, participation and quality of life should be assessed and addressed. And again, can we assess and address the impact of aphasia on healthcare participation for patients with aphasia in hospital? We've got the opportunity when a patient is admitted with the sudden onset of aphasia to begin supporting them to participate in their healthcare from the very beginning. And finally, the strong recommendation from the Stroke Foundation guidelines is that for stroke survivors with aphasia, speech and language therapy should be provided to improve functional communication. Should a priority goal be ensuring that a person with aphasia can communicate about their functional healthcare needs in hospital, this could be a target for intervention. So what I've done here is just map all those Stroke Foundation guideline good practice points and strong recommendations with a speech pathology role in supporting patient-provider communication. So I think, I guess what I'm trying to say here is that there's a lot we could do that would address the patient's medical condition, the treatment, the assessment and treatment of aphasia, and at the same time meet the patient's need for direct, effective healthcare conversations. If you're interested in thinking about this more, there's a freely available Aphasia Access podcast, number 38, that I did with Dr. Katie Strong late last year. And we've also started to think about this in the CRE. So we've created a repository of healthcare communication resources, including aphasia-friendly resources to support healthcare conversations with people with aphasia, particularly about COVID-19. And if you have any additional resources that you think would be really useful to share on the repository, please email Kira and with the original source information and PDFs, and she will upload those onto the repository. And I think this provides a really clear example of how direct, effective healthcare communication will actually protect the health and well-being of people with aphasia in the long term. Thank you.
Thank you so much, Robyn, for your insightful and thought-provoking presentation today. We so appreciate your time, and you've really, as one of our questions states, you've really presented a compelling narrative around the links of communication disability with health outcomes. So thank you so much. I'll go to Slido now for some questions. People are typing away and voting up the most burning of questions, which is great. The first one is, it's fascinating to think about communication disability and adverse events. Should speech pathology teams collect this data routinely to build a case to take to the rest of the team?
Yeah, I think we would be really wise to start thinking about adverse events, because they're so important to healthcare services. They cost Australia billions of dollars a year, and speech pathology, I think, could play a really important role in supporting people with aphasia and other communication disabilities to minimise adverse events.
Thank you. Another question starts with the statement, what a compelling narrative. If communication access is not a current priority for speech pathologists or the wider multidisciplinary team, how do we convince our colleagues to take this on?
I'll get them to listen to this website, this webinar. I've been trying to tell this narrative for a couple of decades now.
Yes.
So I think don't get despair if it doesn't work the first time. Also, I think as speech pathologists, we can be really proactive here. You know, if we interview people with aphasia and we find out what supports and strategies help around specific healthcare situations, then that's really practical information we can give to other members of the healthcare team. And I have never had a healthcare team member say that's not useful. You know, they find it useful because it's practical and something that they can apply immediately. And then we can start drawing the links, you know, for them in terms of protecting people's health in the long term by doing this.
That's right. Excellent. The next question is, it would be helpful to have mandatory training in communication disability for all hospital staff. Do you know if this happens anywhere in Australia or overseas?
I think it might be, you might actually know, Caroline, I think it might be happening in Northern Europe, isn't it? Some countries are doing, was it in Denmark? No, are doing sort of communication partner training across the hospital. So I think there are some examples of that, and I know at St Vincent's Hospital they've created an online e-learning package for all healthcare providers can access to give them support around healthcare provider communication. So it's definitely where we're heading, I think.
Yeah, I know there's training in falls prevention and other mandatory sort of online programs in health networks, and I think it would be really valuable for other hospital staff to know the links between the disability and the health outcomes, so that there's motivation there to put in the communication partner strategies.
I think one way to increase awareness would be to start, even if there were short projects, is to start screening patients on admission for communication difficulty. Because we did that in a study with in Monash on a general medical ward, and we got we screened 50 patients, and 20 of those 50, so 40% of patients, were having difficulty communicating about their healthcare. So this is potentially a really significant issue that's across all wards of the hospital. So it's going to require a whole of hospital approach.
That's right. Thank you. Do you think speech pathologists starting assessment with the IFCE makes a difference to the patient and family versus an impairment-based assessment, that is contextualising language assessment in the healthcare context?
Yes, I do, of course. And what I've noticed when I've done an IFCE and there's been a family member there, is what you're doing from the very beginning is that you are trialling different strategies and you are revealing the person's competence from the very beginning. And that is a really important thing for both the patient to be seen as competent and also the family member to see that the person is still competent, and also that strategies make a difference. Yeah. So from the very beginning, even while you're assessing a person, what you're doing is modelling those how to use communication strategies. You're also modelling that sometimes strategies don't work, and it's not a disaster. It just means that you've got to try something else. And I think patients and family members find that extremely valuable. And it also, from the very beginning, you're sending a message to the person with aphasia and the family member that language might be impaired, but we can still communicate, we can still connect. And that's a really important message to give to patients from the very beginning.
Definitely. It's empowering and would be reducing distress in that moment as well. What do you suggest for patients who initially present with severe receptive aphasia and therefore an initial interview may not be so useful in identifying their needs?
We've, as part of the IFCE resource, we've developed 3 videos that go with that. And one of the videos is an IFCE with someone with global aphasia to demonstrate how you can conduct a limited IFCE and look at the person's ability to communicate about their healthcare needs in the presence of very severe aphasia. The interview looks really different, but what you're doing is you're trying to see what supports does this person need to be able to communicate anything about their healthcare. So it can be as basic as in one of the excerpts on the video, I asked the patient if they'd like anything. They don't respond, so I start offering some objects. I say, would you like a blanket? You know, put it on the person's lap and they push it off and I go, oh, okay, no blanket. But it tells you, okay, they're gesturing with a real object if they don't want something. That's the beginning of communicating about your healthcare. So you can always start somewhere.
Lovely, thank you. Is there something like a short video training about the IFCE, like a mini version of this seminar that speech pathologists can use to explain its importance to other staff?
Not a short training video. There's a long training video as part of the IFCE. So the resource comes with those 3 videos, and the videos are probably about 25-30 minutes in length, and we've got them in 2 versions. One that are captioned so you can see the communication situation that's being interviewed, and then another version where it's not captioned. Okay. But you'd obviously have access to those videos with the resource.
Excellent, great, thanks Robyn. Next one is, how good were the nurses in screening for a potential communication problem?
Well, this was a study done with Sue Lamont and Julianne Coyle at Monash University. And what the study, we published this in 2017. And what we found is the nurses screened the patients after caring for them for at least one shift. So 8 hours of care. And the screening questionnaire is around the nurse's ability to communicate with the patient during attention. Can they tell you what happened to bring them into hospital? Can the patient tell you about pain? So, and the nurse answers each of those questions as always, sometimes, never, or don't know. Mm-hmm. And we found that when the nurses screened the patient using that screening questionnaire, and we compared it with the speech pathologist doing an IFCI, we got very good agreement. In fact, there was 95% of patients identified by the nurses were also identified by speech pathologists. So we thought that was a really neat way to screen patients within that first day of admission. That didn't require the nurses to do any extra training. They didn't have to do anything different about their care routine. They just had to reflect on their communication with that patient over that shift.
Excellent. It's a great result. Do you think we need to develop roles which have protected communication caseloads so that dysphagia can't always take over?
Yes, I do. In fact, I've heard, I was talking to a speech pathologist at the Royal Melbourne Hospital, and she said that she had the role as the communication access person in the department, and I thought that was a very exciting initiative.
That's fantastic.
I think that's, if we start to better understand our role in supporting patient-provider communication around healthcare, I think we'll be able to develop specialised roles in this area.
Fantastic. Is there a time or place for traditional screeners, for example, the WAB at bedside?
Yes, absolutely. So I'm thinking about this bedside interview as being the first contact. But once you've established supports and strategies to enable direct, effective healthcare communication, and if during those interviews, it might be just one, or you might do two, if you go back the next day and do the interview again, and you're getting a sense that the person has aphasia, then you've got an opportunity then to talk to the patient about, I think you're having some difficulties understanding and talking. I'd like to look at that further with you. And then you can do the traditional screener, but you've got it in a context where the patient understands what you're doing and that it's about a specific difficulty in the context of their overall healthcare. And then it fits for sure.
Great. Would it be worth developing a common set of AAC visual supports, etc., around typical health communication in hospitals, including for universal needs like the toilet?
Yes, I think we've all done this individually as we've developed resources, but it would be great to have a repository. And I think there's an opportunity, perhaps through the CRE, to start building a repository of healthcare communication resources for us, so that we can have a visual, picture supports where there's only 4 pictures, some with 16, some with 32, depending on a person's abilities.
Great. How long do you think it takes for speech pathologists to become proficient at using the IFCI SAI? I've tried it once and felt like I was fumbling through it.
It does take some time, and that's why we developed the videos, because I think without actually seeing it being done, it's hard to do. So hopefully the videos will help. We've also created a cheat sheet for clinicians so that if they're doing it in the first couple of times, they've got a cheat sheet there to help them think about what questions to ask next. But it's not a standardised test, it's a bedside conversation. So don't worry if you're fumbling. Sometimes conversations are fumbly. That's okay. What you're trying to do is have a conversation with the patient about their healthcare and see what supports and strategies you can use to make that work.
Robyn, our time is up, but I might just finish with a comment. A person with aphasia joined our seminar and he said, excellent, all care providers should be aware of the difficulties in communicating. Not only the patient needs to be addressed, but the supporters and families in the beginning. I was out of it, so my wife took control. She was kept well informed. So I think that's a really lovely way to finish the seminar today. Thank you so much for your presentation and answering all those questions. We really appreciate it.
Thanks very much for the opportunity.
Bye everyone. Bye Rob.
Bye.